Okay, we have a time for some questions. Excuse me, Vic. And Elizabeth Wiley is going to ask the first question if she's here. Elizabeth? You may ask how I knew that, but.
Thank you. And I think my question, or kind of the first question I have is about the sort of social negotiation and the kind of contrast between the Canadian and the American system that you set up at the beginning suggests that the US system, perhaps the sort of social negotiations haven't been as successful. Certainly the ACA is perhaps a step in the right direction, but you know, we have 45,000 Americans dying each year due to lack of insurance. How can the profession, medicine, sort of initiate those negotiations based on the Canadian experience?
Oh, I'm not sure.
First, you educate the patients and get them to understand that what you want to do is to have a system where the healer can provide the needs of those who are sick and need care. And I think that's where you've got to start.
Well, I was going to start back farther. I think the medical profession, Rosemary Stevens, in a, I think, Milbank article, stated that one of the faults is that no one has been officially mandated from either the government or the medical profession to carry out those negotiations. In a quite an impressive, very lovely quote she used. We use it a lot. And so you don't have a negotiating table, and the medical profession is fragmented. When Jordy and Sylvia wrote that article, it was the end of an era where the ABIM was very active in the field of professionalism. And we were trying to get it to move to the next phase, which would be to try and bring the medical profession, those representing physicians together, essentially to initiate a dialogue. And we were not successful in getting the organization to move there. It moved into another wonderful direction. That's not meant as a criticism. The primary loyalty of most physicians is to their specialty associations. And somehow I think you're going to have to, and I'm talking within medicine, and it, you know, if you want to do it transdisciplinary, it becomes even more daunting. And herding cats, I think it's probably more like herding lions and tigers. It comes to mind. You have to come together and decide what you want. And I'm not sure that you have anywhere near unanimity, nor do you have a place for that to happen. We're lucky. You specifically asked about the Canadian system. Healthcare in Canada is a provincial responsibility under the Canadian Constitution, and with varying degrees of fortitude, it's defended very vigorously. In Quebec, hugely. The federal government cannot intrude into the provincial system, into healthcare directly. It can only pass enabling legislation.
And finance.
And finance. So what's happened is we don't have a single Canadian healthcare system. We have 16 different systems because Newfoundland is different from Ontario, which is different from BC. And our negotiations have allowed for regional differences. There are certainly regional differences in income. Our Quebec people complain bitterly about that. And so it's a complicated answer to to base it on the Canadian system. And I guess I would also say that the Canadian healthcare system was almost imposed on the medical profession. It really wasn't negotiating. A consensus arrived in Canadian society between the late 50s and 1970 when the legislation was finished, that this was where the country was going to go. And the medical profession, this was when Fridson's dominance of the medical profession died in Canada, because the medical profession wanted to set up systems which would allow it to both participate in the healthcare system, but be outside for people who had more money. And our system stated that there was going to be a single payer and a single fee schedule, and you were either totally in or totally out, which meant that everybody was totally in. So I'm not sure how many lessons you can learn. one of the terribly sad things was when you didn't have a public system built into your Affordable Care Act, which could have acted to compete with the private system and would have inevitably, I think, brought down costs. But that's too late.
Just to add that the federal government did have some overlying principles that if they were going to give money to the provinces, which started to be 50-50, and it's somewhat less now, of the healthcare costs, they had to follow these principles, that it was accessible to everyone, that it was portable, that there was acute care, there
Single
was
payer.
access, single payer, et cetera. And as long as the provinces met those obligations, then they got the federal money. So the carrot was there.
I think looking back, I think, Sylvia, you and I probably should have predicted that this notion of an alliance in this country probably was not going to happen for the kind of reasons that you've pointed out. Culturally, the United States and Canada are fundamentally different in the way they orient themselves towards individual responsibility. We are an individualist society. Canadians are much more communitarian, and I think the fact that you've got a single-payer system, you've got that well-organized, although provincially based system is a manifestation of your communitarian value system, whereas
Overall social contract.
overall social contract.
We line up
whereas-
for buses,
Whereas
don't
until
shove,
until the American culture, I think, wakes up to the limitations of individualism, which isn't going to happen in any of our lifetimes, I think we're probably going to be facing this very heterogeneous, chaotic system that we have to figure out how to harness. So
Well,
please,
who do you talk to?
who do you talk to?
I
Exactly.
mean, you've got
talk to
insurance
yourself.
companies,
That's the problem.
you've got,
Yes. Now we're going to hear from the Australian point of view.
Thank you very much. I really enjoyed that talk. One of the challenges for us in health professional education reform is to produce a workforce that's better equipped to respond to priority healthcare needs of society. It seems to me that the discourse about the social contract for individual professionals and professions equally applies, would seem to apply to institutions. So a university, McGill, my own university, has a social contract to be responding to priority healthcare needs with and within society. And so I wonder, would you, and this is of course the social accountability notion, would you draw that parallel, the idea that that our medical schools and other health professional schools are also bound by a social contract, and how can we make them more aware of that social contract?
Well, absolutely. It is, actually John Colleton wrote an article, almost 20 years ago, about social accountability of healthcare institutions, which was a brilliant article, way before its time. The concept of social accountability has taken hold in Canada. I'm sure that Sarita has educated you a little bit on that. The Health Canada and Association of Faculties of Medicine of Canada did a joint study which came out with a document on the social accountability of medical schools. And it was we participated in that exercise, and it stressed social contract, and it stressed links with the community. It stressed that you defined your community, you responded to community needs. But the interesting thing is that that social accountability document is now being incorporated into the undergraduate and postgraduate medical school curricula, and is in the process of being put into the accreditation documents. So we're building social accountability into the fabric of our medical schools. And of course, we've got some schools that are living it. The people from NOSM who are here are living a very well-defined social contract with their region. It's absolutely magic. And lots of other schools in Canada that are doing distance learning are doing so out of a feeling of obligation and a little pressure from the government too, but that usually comes with some dollars and it helps.
We have a couple more minutes if there are other comments or questions. Yes, Lucinda.
I think that the whole social media, big data, information, genomics, all of the other factors that are coming into play in healthcare and in education are game changers. And I wonder if you've thought at all about how they will impact on the ability to create and sustain a meaningful social contract.
I guess they can help.
If we enlist them, if we ignore them, they will do what they want to do. But if we can educate them as to what our problems are, what are the barriers to our being healers, what is making it difficult, I think that they will help us.
I think the social contract, accepted, it's got the word social in it, so it's going to, some people are going to object to it. They're going to add another couple of letters and end up with socialist and so forth. But social contract is generally agreed as something positive in society. You know, people talk about we have to do something because it's in our social contract. I would have thought that this is an area where I don't think we should do it in a very glitzy PR way, but if we say, look we're doing our very, very best to meet what we regard as societal obligations, and we're asking society what it expects of us and so forth, and these are the kinds of things we should be doing.
You're implying that we would get a coherent answer if, in fact, there was a way to engage social media in a way to really get a consensus of the society. And that may be true, but it would be an interesting experiment to try. Yes, Rita.
Thanks. Always enjoyed your presentation, and I always learn something new. I have two questions for you. But first is, in my experience, I've known you both for over a decade and seen you grow with this and actually cultivate a lot of learners in Canada and followers around professionalism. My first question is, what inspired you both to do this? You could have actually finished your terms and gone on and been has-beens or
and
whatever.
gone fishing. We haven't done it yet.
And what inspired you into this field? And my second question is, what advice do you have for learners coming up the pipeline who are observing us struggling with this, and what leadership role do you think they can play?
Well, I will answer the first because it's probably my fault. I was the medical director at one of our big teaching hospitals, and I saw a lot of very good people do some things I thought they shouldn't. And I thought maybe that when we went on sabbatical, when we stepped down from our two administrative jobs, we had to do something. In sabbaticals, you're not allowed to sit around and fish. You have to work. And we had two subjects we were going to do, and one of them was professionalism, and Dick's was what are the qualities of a university that contributes to medical education. Well, we did a literature search of both, and Dick's came up with a whole pile of stuff on tenure. Okay, it wasn't quite what he had in mind. Ours came up with all the wonderful literature in sociology, and some in ethics and some in philosophy, and we started reading. And we read all year, and we read a part of the next year, and it took us about 2 years to sort of put it together. But and it was fascinating because sociologists have been looking at us for over 100 years, and they know us very well, better than we do. And at the time, there was nothing in the medical literature where people, presidential addresses addressed professionalism en passant, but they did not, so we decided that medicine needed to know what sociologists said about us, and then we'd go fishing.
And the second one is sort of interesting. We went through a transformation of what is it? It's kind of interesting. The ABIM project had been going on for 8 or 9 years. The ABIM never got outside the medical literature when it looked at professionalism. Not a single article. Elliot Friedson they'd never heard of. And wonderful people doing it, by the way. Linda Blank was doing that. And consequently, we felt that defining professionalism, then we got into how to teach it, how to assess it, the role of role modeling, its relation to the social contract. These were sort of stepwise things that we've done through the years. Now, I'm not sure if, I think you want to know what we think the future will be. Two things. we're mildly optimistic, but only mildly. It's quite possible that in 25 years, we will not be very professional. We may be very respected employees, but without that commitment, that internal commitment to excellence that comes from professionalism, it will be partly from our own failures, but it'll probably be more from the systems within which we have to function. That doesn't mean we don't keep trying, and I think we're making some progress. Secondly, if we look at where the professionalism movement is going to go, well, two directions. The tyranny of the psychometricians is over.
Not entirely.
Eric has alluded to that. We've been evaluating those things that we are able to psychometrically evaluate, and we missed some things, and some type of structured narrative that can be made reliable is where we're headed. And that probably means multiple narratives, which means a lot of work or some process to analyze them. But of even more importance, we've been talking about teaching professionalism around the world, and we frequently get this question, can you really teach professionalism? Shouldn't their mummies have taught them? And that's not easy to answer. You can answer it because we've been answering it. If we reframe what we're doing from trying to teach professionalism and encourage learning of professionalism, and we've talked to you today about that, to can you influence the development of a professional identity, which in fact is what we really have been trying to do. The answer is we certainly can, and we can make it either better or we can make it a lot worse. So our prediction is that within the next 5 years, we're not going to be talking about teaching professionalism. We're going to be talking about professional identity formation, and we're going to be incorporating that into the existing literature on identity formation, Kohlberg and Erickson and Keegan and those guys. We take people who are not yet fully formed, their identities don't stabilize till the mid-30s, and they're in a very plastic period, and I think we're going to be targeting our educational efforts through the process of trying to understand socialization better and see where we can intervene to make that a more effective and more efficient process so that people can develop their own identities, not so that we can impose an identity. You can't do that. This has to come from them. So that's where we think we're going to be going.
Well, let's join me in hoping the cruises don't go fishing.
Oh.